human growth hormone is believed by many to be one of the most beneficial anti-aging substances due to its ability to reverse many age-related changes. Nevertheless, it is a controversial subject, and we hope that our next speaker will throw some light on these critical questions. He is one of the few serious academic scientists who for many years has supported anti-aging research. Please welcome Dr. Richard Walker.
Thank you very much, Phil, and ladies and gentlemen, good afternoon. I asked for this time slot specifically because I have a masochistic tendency to see if I could do my best under my worst conditions. A couple of glasses of wine and a nice heavy meal sets you right up for a good talk, so I hope I don't put you to sleep. But before I start, I'd just like to say that I have been involved in the organization of meetings such as this, and I am particularly sensitive to the work and effort and expense that the sponsors have gone through to bring us to this wonderful place on this occasion. So I want to express my sincere appreciation for being invited here as a faculty, and IAS and VRP, I really appreciate being here. I'm going to talk today, as our moderator has said, about growth hormone replacement, but before I get into that, I'd like to take us back 100 years before 1989 to 1889, when in fact there was another investigator who, before the birth of endocrinology, had an intuitive feel that things disappear as we get older and should be replaced to restore some sense of vitality and health. And his name, I'm sure you are familiar with, is Dr. Brown-Séquard, and the anecdote of his life and his relationship with his young wife are humorous yet also informative. You recall he was in his 70s and married to a lady in her 30s, and was a bit concerned about his ability to express his full physical love to her. But in light of that consideration, he noticed that the vitality and virility of his experimental animals might be shared with him if he could extract some of that magic humoral ingredients from them. So in the course of extracting their testes and injecting himself, he felt that ultimately, and he announced this to his colleagues as well, the light shined upon him. And just as it was here demonstrated in Life magazine, or presented in Life magazine 1992, that the light shone upon this robust-looking 70-year-old Jerry Gottschalk, who was a part of the experiment that received so much notoriety, an experiment that occurred as a clinical trial, NIH-sponsored clinical trial, that was picked up by the press and actually was the kickoff event, you might say, to the anti-aging movement, which, as you know, has consumed really the imagination of everyone during the last decade and here into the new millennium. So the subject of my talk today then will be about this pivotal experiment, why it was done, and also the outcomes to date. So I'm going to be talking about growth hormone replacement therapy, and specifically I'll be discussing some issues relevant to the administration of exogenous growth hormone, which has been the primary tack in achieving the anti-aging objectives that are imagined or anticipated through use of growth hormone. But I'm also going to address the issue of recrudescence of one's own pituitary gland as we get older, with hopes of stimulating endogenous hormone and restoring more of the body to a youthful or more healthful condition. We can begin this, first of all, by looking at the growing need for the scientific and medical community to meet the needs of a growing aging population. In 1950, while these numbers may not be exactly correct for all sources, we know that the percentage of population of people over the age of 60 years was relatively low, perhaps 10% or so. It was higher in North America and in Europe than it was in Asia and Africa. But after 50 years of the post-war baby boom, it started to increase up to maybe 20% or so. It's growing comparably, but slower, at a slower rate in Africa and Asia. But it's anticipated that in another 50 years, that in the Western nations, as well as in Asia and Africa, perhaps there'll be this continued growth, and perhaps the population of people over the age of 60 will supersede or certainly exceed 30%, and perhaps even go to 40% more. So there's really a growing, important practical need for developing these anti-aging issues and these strategies that we have for maintaining health and vitality during old age. Perhaps growth hormone will play a role in that, and we can discuss that later as a group during the question and answer period. But what we do know, and this is sort of intuitive, but it also can be measured, is that things generally reduce in concentration as we get older. It's not true for everything, of course, but generally speaking, this is true. And we talk about this in terms of trace elements, vitamins, various things that are important in our body. But if we look in the integrative components of the body, the nervous system, as we heard in our prior talk, the reduction of biogenic amines and other components of the nervous system, and the endocrine system as well, we find that after young adulthood, there is a decline in many of the axes of the endocrine system. And this is anticipated, and hence the sort of the reflex response is to replace some of those hormones, if not all of them, and see what the outcome is. The problem being, how do we replace them? How do we put them together, both quantitatively and qualitatively? Growth hormone has been studied for a long time, not necessarily in aging, but certainly in the pediatric arena, because of its important effect on growth. In fact, we know that growth hormone is named that because of its first discovered effect to stimulate growth in young animals, hypophysectomized animals, and in children who are growth hormone deficient. This is a summary of references that show a relative mean 24-hour growth hormone secretion across the lifespan. This is spontaneous secretion in pre-, early, and late puberty, and then the post-pubertal fall, and one can see a remarkable drop here in the 20 and 30-year period, and in the 30 to 60-year range, we see we're almost at the point of the very old. So in fact, spontaneous growth hormone secretion, and I'll show you some of the dynamics of this as we progress, decline very rapidly at a relatively young age. Now this is true not only for spontaneous growth hormone secretion, but also for stimulated. I apologize for this projection. I don't know why that's not showing, but one can see that if secretagogues are administered, specific secretagogues for growth hormone stimulation, one gets an average peak response in people less than 20 in the adolescent range, when we have greatest sensitivity to growth hormone release, something exceeding 30 nanograms per milliliter at that age, and then it progressively falls, and into the over the 40-year range, a injection of growth hormone releasing hormone into a person who one would consider healthy gives a very poor response. And I must say that I've tried this on myself several times because I thought the first couple times it was false reading, but it's very depressing to see that prior to priming, one gets a very, very small response to provocative stimulation. And this is reflected also in the second result, the second messenger in the growth hormone axis, the hepatic-derived insulin-like growth factor, which one sees a concomitant with the loss of episodic release and a reduction in stimulated growth hormone release. There is a decline in insulin-like growth factor. In the course of our discussion this afternoon, though, I'd like to talk about this relationship because very often clinically we like to see these numbers go back to youthful levels upon replacement, which is not always the case, and it's not a goal that we should tend to achieve. However, I'm not going to incorporate that into my talk here. Perhaps we can discuss that later. So, one asks the question then, why did we do this in the first place? Why do adults need growth hormone after they've stopped growing? And the answer is, when we looked at the people who were growth hormone deficient as children, we noticed that they became sick, that is, their risk for disease was abnormally increased. So this was a remarkable observation, because one saw that in growth hormone deficiency resulting either from many sources, radiation of the head, trauma, disease, was accompanied in those children, if it occurred in childhood, was accompanied or was followed later in young adulthood by serious diseases that were reflected in a propensity towards subsequent disease states. And what one saw on a clinical level in these individuals was primarily, the first observation was altered body composition. And we all know these characteristics. We've memorized them many times. The fat mass was increased, lean body mass decreased, skeletal muscle strength was decreased, bone mineral density was down, lipid metabolism abnormal, quality of life diminished. Age-like characteristics, except they were happening early in life. One of the striking effects of early onset growth hormone deficiency without replacement was cardiovascular mortality. And when Dr. Bengtson in 1990 did a survey of the literature and looked at the effects of growth hormone deficiency in aging, he found that both men and women, and of course men and women, showed a greater tendency to die from cardiovascular disease than the expected, anticipated rate of death over a period of time. This is like, whatever it is, 40 years. And this was highly significant. So cardiovascular disease was seen as a general follow-up to childhood-related growth hormone deficiency without supplementation in adulthood. And when one looked at overall mortality, in this particular experiment, or in this particular clinical observation rather, is adapted from Bates in 1996, of 162 patients with partial or complete hypopituitarism. This is not growth hormone deficiency necessarily, but of course it is associated with that. One has a total overall mortality that is observed being nearly twice that of what's anticipated. And those deaths attributable to cardiovascular disease were, again, about twice what would be anticipated in the normal population. So the question then was, if growth hormone sustained health and vitality in youth and it stimulated growth, would its replacement in adulthood prevent some of the sequelae on the cardiovascular, negative effects on the cardiovascular system that were reported? And the answer, quite frankly, was yes, it does. And we can look initially in this analysis at the fact that growth hormone replacement therapy reverses cardiovascular defects in adults with growth hormone deficiency. And here are the results of a paper, and you can't see the reference, unfortunately, but this is taken from a 1999 article by Pfeiffer in Journal of Clinical Endocrinology and Metabolism, which shows reversal of early atherosclerotic changes in people who were growth hormone deficient yet replaced with growth hormone over a period of 18 months. These are the control population. This bar expresses the values for the control populations for intima media thickness of the common carotid and the carotid bifurcation. This clearly would affect blood flow through those vessels, and one finds that upon administration of, or prior to administration of growth hormone, that there's a significantly thicker intima media and consequently reduced blood flow in these vessels for the patients that are growth hormone deficient. But after a period of 18 months, there's a restoration of normal values, and in some cases perhaps even improvement beyond controls as a result of growth hormone administration. When in the same paper by Pfeiffer, and here you can see the reference a little bit better, JCEM 84, 1999, the brachial artery blood flow here in controls and here in pretreatment were clearly different at the beginning of the clinical study. There was much less blood flowing through the brachial arteries of the growth hormone deficient subjects, but after a period of 6 months, the treated and the controls were virtually indistinguishable. So this type of observation was very important and reflected reversibility of early atherosclerotic changes by growth hormone administration. This beneficial effect extended not only to that parameter, but also to changes in myocardial contractility. In the first case, the velocity, that is the rate of circumferential fiber shortening, was accelerated by growth hormone replacement. So here we have this velocity of shortening before growth hormone treatment. Here you have 6 months later a more rapid rate of shortening, and with that, accompanying that, was a fractional shortening was increased. So there's a greater amount of shortening and a faster amount of shortening of the myocardial fibers as a result of growth hormone replacement. So one would expect from this extrapolate to the conclusion that cardiovascular or cardiac efficiency is improved, pumping ability is improved. This is taken from Amato's paper, 1993, JCEM again. How about the effects on body composition we talk? Can we look at these more critically in terms of what is actually happening? Now, this is just a summary of what I said before, but one finds that, and this is taken from a 1994 paper in Endocrinological Metabolism, the mean changes from baseline, that is, before administration of growth hormone for 18 months, one finds that there is a highly significant 0.001 decrease in fat mass. There's a significant, again at the 0.001 level, increase in body cell mass and hydration state as well as a result of growth hormone administration. Again, not to normal people, but to growth hormone deficient people. If we quantitate some of these changes in growth hormone mediated changes in body composition, we see that, first of all, the lean body mass is increased. We talked about this, it's been mentioned before. A significant change occurs in lean body mass, not significant at 1 month of treatment, but significant after 6 months of treatment. Let me say, and I'll address the issue of dosage later as we get along, this dose used here was relatively high. I mean, it's actually quite high. We're talking here in the range of 20 to 30 micrograms per kilogram, which is a whopping dose considering what we're talking about in terms of replacement during aging, and I'll discuss this more. We were looking at the range of maybe perhaps 2 to 5 micrograms per kilogram. Nonetheless, one got this dramatic effect in a very short time. I would not anticipate, or would want you to anticipate, in the range of doses that we're using to see these kind of dramatic effects, especially because the people who will be treating will be not as extreme in terms of their deficits as these people were. But in any event, one saw this dramatic change in lean body mass. Fat mass is decreased as well, and here you see the change again within 1 month. There's a reduction in fat mass paralleling the increase in lean body mass, and after 6 months again we have significant differences between the treated and the control groups, the non-treated group, the placebo groups, okay? So these are all growth hormone deficient, just that some of them got placebo. And finally, and perhaps most importantly, no significant difference in body weight. So we're really getting a reconstruction, reorganization of the body in terms of its fat and muscle composition rather than loss of weight and hence relative reduction of weight and fat as a result of weight loss. And here's another very interesting thing, and actually this is one of the striking issues that relates to what we're looking for in treating or growth hormone replacement and aging, is that the effects of growth hormone mediated on adipose tissues is different for the different tissues. So if we were to look, for example, at the legs and the subcutaneous truncal fat, visceral depots, arms and head and neck rather, significant values are achieved for most areas, except in this experiment, the legs, but the greatest effect occurs in the abdominal regions. So this is what has been touted as being a desirable effect, obviously, as we get older, because we get that midline expansion. And so hopefully this expression of growth hormone's effect on adipose tissues could be extended to the aging condition. This was taken from Bengtson's study in 1993. Here is a pictorial, presentation of what was previously done numerically or graphically in the last slide. It's again is taken from Bengtson's same paper. It's a CT scan at the level of 3-4, L3-4, and again the period of treatment is 26 weeks, and the dose is 26 micrograms per kilogram, and you can see in the untreated condition this quite obvious fat layer, which is visually obviously shrunken as a result of treatment. So this is a striking demonstration of the efficacy of growth hormone to sort of get rid of abdominal fat, if you will, as part of its restructuring capabilities within the body. How about effects on serum lipids? This is an interesting experiment because it differentiates not only the effects of growth hormone on different kinds of lipids, but on different ages as well. The dark bars here and here and here and here represent data taken from patients that are greater than 65 years of age, as compared to those who are less than 65 years of age in the open bars. And what we see is that total cholesterol and LDL cholesterol are significantly reduced in both age groups, but there seems to be a greater benefit in the older patient. Now, I've seen the same thing in laboratory animals, and it's quite dramatic. The changes are not ambiguous at all. They're striking, and in our cases, and I'll show you some of the data as we get to the animal studies at the end, that these are unambiguous, serious changes in animals that are healthy but old. Okay, so one sees a greater tendency for the elderly, in this case clinical studies, to benefit from growth hormone replacement. This was taken from just a recent paper in Clinical Endocrinology 2000. Okay, how about effects on bone? Now, one of the considerations we heard from our last speaker was that there's changes in bone that occur as a result of aging, and indeed, we know that's true. Bone resorption occurs, demineralization is obvious. This is accelerated significantly in people with growth hormone deficiency. Yet if we take those people, and these are two different references showing the dramatic effects of growth hormone replacement in those people, in this case on forearm bone mineral content increasing over a period of 30 months. This is a slow response now, as you would expect, and here over a period of 18 months in the neck of the femur and the trochanter, all of these individuals being growth hormone deficient, showing a comparison between baseline and after various durations of treatment. If one looks at total bone mineral content, we get the same picture, that over a period of 60 months, there's a progressive and continuous increase in bone mineralization. I don't know what happens beyond there. We would hope somewhere sooner or later this stabilizes, and I'm sure that's dose-related. But in any event, this progressive increase in bone mineral content is, again, not ambiguous. It's been reported many times, and here it's taken from Termatin a JCEM paper in 1999. Presumably, these effects on bone are mediated by IGF-1, although I'm not sure about that, and we can discuss this later, because there's a colleague of ours in Miami who claims that intra-articular injection of growth hormone has a direct effect on cartilage, bone cartilage, but that's another story. But the effect on bone mineralization presumably occurs as a result of IGF-1 activation of the pre-osteoblast or directly on the osteoblast, which in turn then causes development of new bone and activation of the osteoclast. And this process, of course, initiates osteoclastic activity. We all remember from our early physiology classes. And when this then happens, we apparently get the bone resorption by the osteoclast releases IGF-2, which in turn activates a protease, protease 4, which then acts upon IGF binding protein 4 to release free IGF-1, and the cycle goes round and round. So it seems like if growth hormone has the capacity for this induction of bone remodeling, it seems to be mediated through its ability to first initiate high levels of IGF-1, or not necessarily high levels, but increased levels of IGF-1, and this in turn is then fed back upon by the actual bone remodeling process itself. We had some discussion about decline in workload. I think this is a commonly known phenomenon. As we get older, our ability to work at a given task, or our maximal workload declines as a function of time. This is one of the issues that we would like to study when we look clinically at people who are normal, so to speak, have normal growth hormone functional axis for their age, but in fact, if we could sustain their ability to work, or their ability to undergo physical activity at the levels that they had prior, 5 years or 10 years prior to being treated. Here we have a study involving showing the decline of workload, maximal workload capacity in untreated people compared to the increase actually in workload capacity as a result of growth hormone replacement. But with regard to changes in oxygen consumption, we have a parallel graph to what I just showed you for workload. Over a period of 5 years again, Termatin reported that he found a reduction in oxygen consumption here, 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 and here, and yet in people treated with growth hormone, there was an actual increase higher than the preceding values for the 5-year initiation period. So these observations, as well as the fact that the restoration of growth hormone, or the presence of growth hormone through replacement, also facilitates healing, was very exciting. In this particular study, which came from an aggregate study that was run in Europe and in the United States, just published in a book this year, we find that for donor healing sites, for 3 different sites, placebo compared to growth hormone replacement is significantly different in that healing of, during transplant studies, healing of the donor sites was accelerated nearly twice as fast in the people receiving growth hormone as compared to those not. These are not growth hormone deficient people. I beg your pardon, these still are growth hormone deficient people. And then finally, before I leave this topic, we'll look a little bit about quality of life. Now, this is a very subjective criteria, very subjective in terms of you've got to obviously take the patient's the patient's word for what they're feeling. There's a big placebo effect here, obviously, but nonetheless, the Nottingham Health profile indicates that growth hormone deficiency is accompanied by a reduced quality of life. And this is especially true for areas involving energy, physical mobility, and social isolation. Now, you see that there are highly significant differences in energy. For the higher score indicates a poor quality of life. Okay, so you have a very high score here, 23 compared to 7.8. It looks like so energy is highly significantly reduced by growth hormone deficiency, as is physical mobility. Okay, ambulatory behavior and social isolation. This seems to impact most on youth, and while these are taken for children later in adulthood, early young adulthood, but this sleep parameter, interestingly enough, does not come on until later in life. These individuals reported in this study, I believe in 1994, were young adults, and their growth hormone deficiency resulted from damage to the pituitary or the peripheral organs. Doesn't talk too much about none of these people who experienced irradiation of the brain for malignancies, the tumors of the brain, are included in this study. It might be said, and I know this, I don't have the data to show you, unfortunately, that sleep parameters are affected when one has damage to the brain resulting from radiation. This has to do with growth hormone releasing hormone that we'll discuss subsequently. So in any event, these scores in this particular study were shown to decrease upon growth hormone replacement in these growth hormone deficient people. So we've gone a full spectrum then from body composition, musculoskeletal characteristics, cardiovascular parameters, skin and tegumentary changes, quality of life. Many things are affected by growth hormone deficiency that seem to be reversible by growth hormone replacement. The question then is, one, are we really growth hormone deficient as we get older? And is there any evidence to that effect? And I guess the first thing, or the thing that's been used to initiate the studies that have been run over the past decade, is the fact that the physiological changes resembling those during aging are the same as those which I've just reported to you for growth hormone deficiency. And so if we look as a function of time, and we see what happens with regard to metabolism, mental acuity, and IGF-1 levels, HDL cholesterol, lean body mass, and fertility, and libido, we have a reduction in these parameters, and they're concomitantly associated with increases in lethargy, weight gain, abdominal fat, everything we find to be not only aesthetically not pleasing, but bad for our health and survival. So the question is this a reflection of growth hormone deficiency as it seems to be in the pathologic model? It may be, if it is, that the normal concentrations of growth hormone as we get older are in fact not adequate to sustain vital functions and therefore increase our risk of disease, just as we see it in the frankly and severely growth hormone deficient people who are younger. There's a way we can test that, obviously, and it's what we've been doing over the past decade. We give hormones back. But which one should we give? I mean, we've got here you see there are several. We have human growth hormone. This has been used the most, and we'll discuss this to some extent, but I want to take you somewhere else before we do that. This is a hepatic site of action, okay? It essentially cuts off the head. We really don't need the suprahypothalamic, we don't need the diencephalic components, we don't need the infundibular and pituitary elements, we don't need anything except the liver, okay? Is this the best modality for treatment? How about IGF-1? That's coming on the market. Maybe it is on the market here, I don't know. I know that Genentech was producing a recombinant product. Can it be used? We don't need anything here except a tissue receptor. Of course, some people don't have tissue receptors, the Lerone dwarf, for example, but we're not talking about that. We're talking about the normal aged person. How about growth hormone releasing hormone. This is available, and it's marketed in the United States, I'm not sure in Europe, as Geraf. It's made by Serono. It's not the natural growth hormone releasing hormone that occurs in the arcuate nucleus of the hypothalamus, but it's the truncated version. It's a 1 through 29 amide of the natural molecule, and the reason the small molecule is used because it's so expensive to make by chemical synthesis that it restricts the cost to the public. There is, and I've said this in other lectures, a company that's developing this by recombinant technology that should be available in a couple of years and will drive the price way down and should be a very effective compound. The GHRPs are molecules that you may or may not have heard about, but they are xenobiotics that occurred or were discovered by a colleague of mine by the name of Cyril Bowers, who is at Tulane, and he was working with Beckman in the 1970s, and he was trying to create artificial analogs of the pituitary hypophysiotrophic peptides, and used enkephalin as a initial model to work from. And he modified that molecule and came up with a hexapeptide. It's his-D-trip-allotrip-D-phenylamide. It's a 6 amino acid peptide with 2 internal D amino acids, which makes it resistant to degradation. And that had a very weak growth hormone stimulating action, but it was a very potent stimulator of growth hormone when in combination with GHRH. So its synergistic action was very important. Now, Dr. Guizot, Italian investigator who's been working very actively on this model, has shown, suggested at least, hasn't proven yet, that the GHRPs require at least a functional hypothalamus. So if we were to look at this in terms of hierarchy, here we're at the lowest level of action, we're at the receptor level. Here we require a liver, here we require a pituitary, here we probably require some component of the brain, and together we get a very good and active response, and perhaps this is where we're going in the future with regard to recrudescence or reconstruction of an active growth hormone axis in aging adults, during aging. So let's look a little bit in this last half of my presentation at the levels of growth hormone secretory defects that occur. Let's start here at the bottom. End organ resistance, I mentioned the Laron dwarf, is a growth hormone deficient state in which the actual complete axis is intact, except the receptors for IGF-1 are missing. So you can't do very much with that, and it has no relevance anyway to the subject that we're talking about. The intermediate level, IGF-1 deficiency, has to do obviously with hepatic defects and receptor deficiencies, perhaps at the liver, interactions with other hormones like estrogen that might alter the effect of growth hormone upon its receptor sites in the liver. This is also really not relevant because we know the people we're discussing in this conversation are those who have had an effective and functional growth hormone axis prior to becoming elderly. The pituitary. Now, in growth hormone deficiency, pathogenic or pathologic growth hormone deficiency, we could have empty sella, for example. So we could have growth hormone deficiency as a result of the absence of a pituitary gland itself. Or the pituitary could in some way have a defect that it produces an inactive form or morph of the molecule which is not effective in the periphery. So dysregulation of growth hormone secretion, on the other hand, is something that might have relevance to aging because this could result from the temporal disorder of stimulation of the pituitary gland, which is very possibly a source of growth hormone deficiency in the age. But most likely, growth hormone deficiency occurs as a result of disorganization of higher levels. Hypothalamic, and I should say suprahypothalamic as well. There could be growth hormone releasing hormone deficiency, there could be somatostatin excess, or there could be a temporal disorder in terms of interactions of those in combination with suprahypothalamic signaling. So let's look at the secretory cascade. I went a little bit too far, but anyway, let's look at this so we can get some concept of what we're talking about. And this is relevant also because, as I'll show you, or as you know, there's another category of compounds which we haven't discussed, like the VRP product, the Pro-HGH, which provides stimulation of the brain, not specifically at the pituitary, but up here in the cortical regions. It causes perturbations in neurotransmitter pathways, the biogenic amines, and other, histaminergic or GABAergic pathways, or in the neuropeptide components that are suprahypothalamic that impinge upon the diencephalic sites, the arcuate nucleus and the medial basal hypothalamus, where the actual specific neurons that stimulate the pituitary reside. Okay, so we can get non-specific stimulation of these higher signals to indirectly work upon those neurons that are residing here, the neurosecretory neurons that actually deposit their secretagogue factors into the plexus that stimulates the pituitary. So the neural pathways then impinge upon the hypothalamic cells, then the hypothalamic cells modulate growth hormone secretion directly. It's this relationship, I believe, that is aberrant in aging and has to be treated through interventions that are subtle, but yet will bring about a restoration of what appears to be normal physiological function. And when we think about that, we have to look a little bit about the organization. Let's recall what we have here. Okay, in this cartoon, it shows that neural stimuli, as I just showed you, coming from suprahypothalamic sites, impinge upon cells primarily in the arcuate nucleus, although they are distributed throughout the hypothalamus, as you know. And they influence then the secretion of the inhibitory factors and the stimulatory factors, which are then transported through or collected in this capillary plexus in the diencephalon and then transported through vessels in the infundibulum down here into the pars distalis. So they in turn reach the somatotroph and then cause modulation of growth hormone secretion. So you can imagine the complexity of signals to get this to work right. I mean, clearly, when one thinks about the events that occur in the reproductive system of the female, one gets a better idea about it because we know that ovulation was a peripheral event. We can sort of visualize that easier. But the same thing is happening here in the brain. We have to have, for the growth hormone axis, we have to have a coordination of suprahypothalamic signals to modulate the activity of these diencephalic neurosecretory cells, to deposit their peptides into this plexus, to come upon the pituitary cells that actually cause secretion in an appropriate fashion. And this then is expressed appropriately. And here is just another cartoon to show the complete axis. Again, to reiterate, I'm not going to waste any time to go over this again, but a growth hormone releasing hormone stimulates the production, and you see that comes from the brain. The SRI, the somatostatin, inhibits growth hormone production, release, and activity. And this thing, GHRP, exists, well, I'll show you that in a second. GHRP seems functionally to work by modifying the activity of GHRH, either to stimulate it or to facilitate its action, and to functionally inhibit the activity of somatostatin, so that the releasing impact for growth hormone upon the pituitary is amplified. Of course, then you have the feedback relationship with IGF-1 as well. basic endocrinology. We don't have to go through that. But let me say something about this GHRP before I move on. GHRP was invented, it was synthesized by accident in 1976 by Cy Bowers and his team at Beckman. But last year, a Japanese group reported finding a 28 amino acid component that had the same binding characteristics as GHRP and other analogs of this molecule, and it was extracted from the gut. Now, perhaps that's really relevant considering what we heard in our last talk, but this gut molecule, is 28 amino acid ghrelin, somehow finds its way to the brain to involve itself in regulation of growth hormone, or it's produced in the brain. However, I must say it has not yet been extracted from the brain. So it's very possible that this peripheral source of ghrelin somehow finds its way either through the circumventricular organs into the circulation of the diencephalon, or in fact it's produced in the brain. We don't know yet. But clearly we do know that the regulatory axis not only involves a stimulatory component and an inhibitory component, but it now also contains a facilitatory component which may in fact be involved in the process of regulation of growth hormone release. So, aging seems to be associated with maladaptive changes in the growth hormone neuroendocrine axis that resemble pathogenic growth hormone neurosecretory dysfunction. The reason I bring this up here now is because there seems to be anyway a model, a clinical model for aging that occurs in children. It's called growth hormone neurosecretory dysfunction, in which the kids have an entirely normal growth hormone axis, but they don't seem to gain full benefit from the growth hormone that they produce. And this is not a result of any kind of deficiency of receptor or capacity to produce growth hormone, but it seems to be more as a result of a regulatory dysfunction similar to that which we see in aging. This is a demonstration of degrees of change in endogenous growth hormone secretion that occurs over a 24-hour period here in normal controls. You see that there are these ultradian spikes that occur, and then associated with sleep, there is a high peak of growth hormone, endogenous intrinsic growth hormone release, and this goes throughout the day, and it repeats itself over and over again. Well, if you look at kids with growth hormone neurosecretory dysfunction, you get the same kind of patterns except they're attenuated. They're not obliterated like in growth hormone deficiency, either severe or partial, but they're just blunted. And if you were to take, and I apologize for not having a slide to this effect, but if you were to take snapshots of spontaneous growth hormone release in adults as they age, you see this type of progressive blunting. And so this attenuation in GHND seems to resemble what we see in the elderly as we get older and older. And what's really interesting in this model is that it seems to also mimic many aspects of what we see, especially with regard to sleep. Here, for example, high amplitude peaks occur in the control, the normal individuals, as I showed before, during sleep. Here you have nearly halving. These are multiple individuals, as you can see, but the blunting is statistically significant from here to here for your mean values. This is growth hormone deficiency, and it's totally out of the picture. It's not even relevant. But this and this seem to be related by degree. So the peaks are absent or severely blunted in severe GHD, and we're not worried about that. Now, what happens when you stimulate or you inject either intravenously or subcutaneously with growth hormone releasing hormone? Well, Mike Thorner did a lot of this work many years ago when the product became first available. Actually, this wasn't commercially available, but we had it for research purposes, that if you inject growth hormone releasing hormone within a period of 15 to 25 minutes, you initiate a peak that's quite significant. When you look at individuals with growth hormone neurosecretory dysfunction, a high stimulated peak occurs for controls, an attenuated peak occurs for those kids compared to growth hormone deficiency where it's practically absent. So we have this blunted response, which is similar to that which we see in aging individuals. Now here's an experiment that Dr. Burkiw and I did last year or 2 years ago. And what we saw was very interesting. We used growth hormone releasing peptide. Now this is not GHRP6, it's GHRP2. This is just another version, another molecular modification of the GHRP family. And we found that in the young men and in the adult males, us included, so we're also in this sample, through nearly normal and regular responses to this stimulus. But when you looked at growth hormone releasing hormone, kids did this kind of response, greater than 30 nanograms per mil, and we did less than 5. Very depressing. So it seems to indicate the pituitary, for some reason, was unresponsive to GHRH, either because it was not used to being stimulated by GHRH or because it had no capacity to respond. And so when we looked beyond that and we primed, we started giving GHRH, we found that this was the effect before treatment after 10 days, and we see we're around, you know, some of these people, including myself, was less than 2 nanograms per mil, very depressing, but after 10 days, we're up here above 10. So this was very exciting because it correlated with animal studies which we did, in which we showed that recrudescence of the pituitary does occur and could occur in old animals, and apparently is also possible in aging individuals, aging humans. In terms of infusion studies and restoration of this is very important and exciting work that was done a while ago, a couple years ago, not too long. I think it was by Thorner's group. One of the things that we see as we get older is attenuation of, if you got to look at 2 lines here, there's a dark line or a dark spot, and then there's open circles. Well, the open circles reflect an untreated elderly group in which there's attenuation of spontaneous episodic release of growth hormone. When you administer growth hormone, you inject it, you get this spike right away. But if you keep infusing it constantly, you infuse it all day. Now, of course, you're not going to walk around with an IV in your arm, but in these patients in the hospital, they were willing to do this in the study. What was found was very exciting, is that the amplitude of their spontaneous spikes increased as a result of the presence of growth hormone in a constant infusion. And to test this farther, this seemed to be dose-related. If you gave a higher dose, this is 0.05, 50 micrograms per kilogram. Here it's 100 micrograms per kilogram. You get a much larger initial spike, and you get bigger episodes compared to the control. And when you stop, you lose the episodes. So it seemed to be that the infusion is dose-dependent. It initiates pulses, and those pulses, again, can be restored. And this was done by Chapman. I was right. It's a Thorner paper done in 1996. Chapman was the first author of Thorner's laboratory in the University of Virginia. So that was a pretty dramatic and interesting demonstration that the neural machinery, if you will, is still there for signaling to the pituitary, but it's just got to be awakened. It's got to be rejuvenated, so to speak. And it can occur to some extent by single injections, as we showed, for pituitary rejuvenation, and also by constant infusion, you really get the dynamics returning. Now here, some of the factors then causing the decline in age-related growth hormone secretion is the increased somatostatin. We know that occurs in animals. We're not sure it occurs in human. Reduced growth hormone releasing hormone seems to be a sure thing. At least from data that I've just shown you, it seems that people, for some reason, lose GHRH, either because it's not being produced by the hypothalamus, or it's being suppressed by somatostatin or some other factor, or it's not being appropriately signaled. But when you replace it pharmacologically, you restore the response. Reduced growth hormone production and reserve in the pituitary undoubtedly occurs, and I'll show you in my closing slides why that's true. And perhaps ghrelin is also involved, but we haven't yet been able to figure out how that might be involved, how that might work. Now, this is an experiment that I hope that I don't bore some people with because I've showed it before. I love it so much. It's one in which we took some old rats, and these guys were real old. They were they were greater than 22 years old, almost 3 years old, and we gave them for 90 days injections of growth hormone, releasing hormone, and GHRP. And then we did a northern blot for messenger RNA in their pituitaries. And we found that in the old animals here, this represents the message for, this is saline treated, okay? So the growth hormone, the messenger RNA in the saline treated controls was virtually absent. There was no growth hormone messenger RNA compared to the young animals who were saline treated who had lots of messenger RNA. But when we treated the old animals with GHRH and GHRP, we got all kinds of growth hormone restored. In the young animals, it didn't make any difference. They were going anyway, so what we did didn't seem to have an effect. But the effect on growth hormone was dramatic for the treated compared to the untreated. You couldn't even, we only found these two, out of 6 animals, we only had 2 that were evident. And clearly, there was a wonderful recrudescence as a result of growth hormone stimulation of pituitary in these old animals. So we published that in 1994 in Endocrine, and here we have a quantitative presentation of the effect on the pituitary gland growth hormone content. Saline treated animals were low, growth hormone releasing hormone high, and GHRP plus GHRH high. And here's the messenger RNA correlates with growth hormone concentrations in the pituitary. So this message that we stimulate clearly is translated into growth hormone that's ready to be secreted and part of the pituitary reserve. So in conclusion then, and I've just got about a couple of minutes left, I'd like to say that our concerns now are what is the best modality for going into future studies of a growth hormone deficiency. It's my opinion that recombinant growth hormone is very good after you show that the system is not responsive to secretagogue stimulation. So I might say that in terms of at least initial trials, one would give a specific secretagogue like GHRH, and then perhaps a non-specific secretagogue with it, such as pro-HGH, to bring together both a neurogenic, non-specific, and specific stimuli to see if one could start up the pituitary again. If that was not successful, then one would go to the next step and forget about the head, forget about the pituitary, and go into direct stimulation of the liver. That's important, of course, but what's also important, if perhaps more important than anything, are the safety considerations. And here what we find is that even with recombinant growth hormone, there are not serious effects, but there are effects which must be taken into consideration. This is just some data that was reported for Neutropin, but it's the truth for many things. Any brand of recombinant growth hormone. One has, at a dose-related edema is inevitable. I mean, you could get rid of this effect by reducing dosage, but this occurs very commonly in doses 10 micrograms per kilogram or higher. Joint pain occurs actually lower than that. I personally have experienced this at a dose of something in the range of 4 or 5 micrograms per kilogram. I believe it can be titrated out and still retain the positive benefits of growth hormone. Carpal tunnel syndrome is not that common, but it does occur. We know that the clearance of growth hormone is going to be affected by P450 enzymes. That's common for anything, so of course one has to be careful about using growth hormone in the presence of those other compounds. And the fetal effects are unknown, so clearly this type of treatment is contraindicated in pregnant women, but then again, we're not talking about that age group primarily. We're talking about people in their later 40s, perhaps 50s and 60s and beyond. So, and then in conclusion to my talk, I'd like to say that disease and age-related endocrine deficiencies are analogous and perhaps homologous when we consider growth hormone neurosecretory dysfunction in children as a model for age-related growth hormone deficiency or growth growth hormone insufficiency, I guess is a better word than growth hormone deficiency. Therapy may, in fact, will bring about benefits. However, we must be cognizant of the fact that there are side effects. One of the striking things about the pituitary secretagogues is that they are essentially free of side effects because they only create an episode of growth hormone release, as you've seen, area under the curve much smaller than that which you would expect and in fact do get when you inject recombinant growth hormone. That gives a big square wave, square pulse, and so the toxicity of that type of presentation is much greater, and in fact one can anticipate that. So long-term replacement at physiological doses should maximize benefits and minimize side effects, which is why I suggest the use of secretagogues as an initial strategy. I believe that the hormone replacement will be a significant part of the future wellness programs. As a matter of fact, I think this will continue on through the next decade and farther until we get into gene intervention therapy, when in fact these hormones and restoration of these vital substances can be done by signaling the gene to create those those proteins directly. Currently, growth hormone replacement is investigational, and it is our feeling that they should be performed under protocols, especially if there is regulatory scrutiny, and in any event, it should be done for the purpose of data gathering and knowing, in fact, where we're going with this type of therapy. And hopefully, we'll reach a point where we'll be like Jerry, healthy and in good health for as long as we live. Thank you very much for your attention.